Hello coders! Today we're going to be talking about ICD-10 Chapter 2 Neoplasms, which start at code C00 and go to D49. So I would like you to make sure you're following along in your code book where you have your Chapter 2 General Guidelines. So Chapter 2 reminds us that all ICD-10-CM codes contain the codes for most benign and all malignant neoplasms. Okay, so let's remember, benign is non-cancerous, malignant is cancerous. Certain benign neoplasms, such as prostatic adenomas, may be found in the specific body system chapter. So a prostatic adenoma is an overgrowth, a benign overgrowth of prostate tissue. And so for that case, that one's going to be found in the genitourinary section and not in the neoplasm section. Now, to properly code a neoplasm, it is necessary to determine from the record if the neoplasm is benign, in situ, malignant, or of uncertain histologic behavior. Okay, so we know benign is non-cancerous, malignant is cancerous. In situ is a very specific type of cancer. In situ means localized to one area without spreading. So, for instance, cervical cancer tends to be in situ, meaning it just invades the cervix and it doesn't invade other body parts. Now, to code for an in situ cancer, the doctor must note that it is in situ. They need to tell us what type of cancer does the patient have and what's the status of that mass. We also have something called uncertain histologic behavior. This is something that pathologists will document, saying that it may become cancerous in the future. Right now, the cells look abnormal, but they're not cancerous yet. And so for all of these, the doctor needs to tell us whether it's non-cancerous, localized, cancerous, or might become cancer in the future. Okay, so that's number one, we need to know. Now, if malignant, any secondary or metastatic site should also be determined. Okay, so most of the time, our cancer stays in one area, but if it can get into the blood supply or the lymphatic system, it likes to metastasize or spread to other sites. So there are other words we might see. We might see metastatic. We might see metastasis. We also might see METS, M-E-T-S for short. You might also see the word spreading. You might see the word invading. And so, again, those are different terms the doctor needs to let us know, and needs to let us know that one tumor is related back to the original tumor. So if someone has prostate cancer that has metastasized to the bone, okay, prostate cancer is primary because that's where it started. The metastasis to the bone is considered secondary, okay, meaning that's where it spread to. Primary is where it started, secondary is where it spread to. And I want you guys to keep in mind that one primary tumor can spread to a variety of body parts, and each one of them is considered a secondary site. So let's say the patient has lung cancer and it has spread to their liver, their spleen, and their kidney. Okay, so the lung cancer is primary. The liver is going to be secondary, the kidney is going to be secondary, and the spleen is going to be secondary, okay? Because they all spread from the primary site. So we're going to keep that in mind as we go through the guidelines. Now, on occasion, primary malignant neoplasms overlap what we call site boundaries, okay? So it goes on to tell us that a primary malignant neoplasm that overlaps two or more contiguous next to each other sites should be classified to subcategory or code 0.8 overlapping lesion unless the combination is specifically indexed elsewhere. So again, if we do not have a specific code and it talks about an overlapping site, then we need to look for the cancer and we're going to put a 0.8. Okay, now for multiple neoplasms of the same site that are not contiguous, such as tumors in different quadrants of the same breast, code for each site should be assigned. So again, we only use a combo code when they are touching each other. If the tumors are completely separate in the same body part or in separate body parts, we are going to code them separately. Okay. Now, we also have something called malignant neoplasms of ectopic tissues. Okay, so ectopic tissues are tissues from one part of the body that grows in another part of the body. So when we get to pregnancy, we talk about ectopic pregnancies, pregnancies outside the uterus. Ectopic tissues are tissues outside the organ. And so what happens is malignant neoplasms of ectopic tissue are to be coded to the site of the origin mentioned. Example, ectopic pancreatic malignant neoplasms involving the stomach are coded to malignant neoplasms of the pancreas, unspecified. And so what has happened in this ectopic tissue circumstance is that we have tissue, we have cancerous tissue from one organ, in this case the pancreas, making its way into the stomach and creating a tumor there. Okay, so these are kind of rare. Same thing with the overlapping, but I want you to know these guidelines because these are the types of things that show up on credentialing exams. Okay, so now let's talk about how do we even find these codes, and then we'll go through the rest of the guidelines. Okay, so the neoplasm table and the alphabetic index should be referenced first. So what we have at the end of our alphabetic index, we have our drug and chemical table, and then we have our neoplasm table. So the first thing we should be doing is going to the neoplasm table. However, if the histological term is documented, that term should be referenced first rather than going immediately to the neoplasm table in order to determine which column in the neoplasm table is appropriate. For example, if the documentation indicates adenoma, refer to the term in the alphabetic index to review the entries underneath this term and the instructional note to, quote, see neoplasm by site benign. Okay, so the table provides the proper code based on the type of neoplasm and the site. So again, remember the direct anatomic site. So if we're given the full histological term, like, again, a prostatic adenoma, okay, or melanoma, or something like that, we can look up that term in the regular alphabetic index. But if we are given the body part, if someone says prostate cancer, we go to the neoplasm table, and what we're going to do is we're going to look through the table until we find the word prostate. And then we need to find the correct column. So our columns that you're going to see are going to be primary cancerous, secondary cancerous, then we're going to see in situ, we're going to see benign, unspecified behavior, and unspecified. Undetermined behavior and unspecified. So again, we always want to make sure whether we are using the alphabetic index or the table, it reminds us the tabular should then be referenced to verify the correct code has been selected from the table and that a more specific site code does not exist. So again, we always are going to check either in the alphabetical or the table and then double check the tabular. Okay, and we always want to make sure we are getting as specific as the example gives us. So let's talk a little bit about treatment, okay? We have three main types of treatments that we use when it comes to cancer, okay? So the first thing is radiation therapy. So we use radiation and we use different radiation beams to get the radiation into the body. Radiation tends to shrink tumors. We also use chemotherapy. Chemotherapy is chemicals. We put the chemicals into the bloodstream to help destroy the cancer cells. And we also have immunotherapy, which is used for certain cancers and leukemias, in where we're dealing more with the immune system and we're basically trying to reboot the immune system. Okay, these are our three main therapies. Of course, we also do surgery as well. So the first thing that we need to know is, what are we doing for the patient today? So if the treatment is directed at the malignancy, designate the malignancy as the principal diagnosis, okay? So again, if the patient's going to meet with the doctor in the office, the main reason for that is the cancer. So that's going to go first. The only exception to this guideline is if a patient has an admission solely for the administration of chemotherapy, immunotherapy, or radiation therapy. Assign the appropriate Z51 code as first listed or principal diagnosis, and the diagnosis or problem for which the service is being performed as a secondary diagnosis. Okay, so this is the way to think about it. We always need to remember, what is the patient coming here for? So if the patient's coming to the office to have a follow-up for their prostate cancer is going to be the primary diagnosis. But if a patient is going to have radiation therapy, chemotherapy, or immunotherapy, that's the reason for the visit, is the therapy. So the therapy code would go first. Then we would put what we're treating. The type of cancer would go second. It's only for those three: radiation therapy, chemotherapy, immunotherapy. So again, if patient's going for therapy, therapy goes first, then cancer. If patient's going for a follow-up or testing for their cancer, cancer is going to go first, okay? So again, think of it more as when they're going for a therapy, therapy code goes first, okay? Now, what we hope is that the patient only has one tumor, one cancer, but that doesn't happen usually. A lot of times people will get a metastasis, a spread of cancer. So it's telling us, when a patient is admitted because of a primary neoplasm with metastasis and treatment is directed towards the secondary site only, the secondary neoplasm is designated as the principal diagnosis, even though the principal malignancy is still present. Okay, so remember, why is the patient here? So if the patient has two different types of cancer, okay, patient has prostate cancer that metastasized to the bone. And today we are talking about the bone cancer. The bone cancer is going to go first, then the prostate cancer. We don't forget about the prostate cancer, okay? It just doesn't get coded first, because remember, why is the patient there? Today the patient is there to talk about their bone cancer, or today the patient is there to get a diagnostic test for their bone tumor versus their prostate cancer, okay? So again, when patients have more than one tumor, we need to be very clear in the documentation what is happening today and on which tumor, okay? And then, of course, as we've been talking about, when it comes to the tumors themselves, we need to know, are they benign, malignant, in situ, or uncertain behavior, and are they primary or secondary, okay? So it goes on to tell us that, again, the secondary neoplasm is designated as the principal diagnosis, even though the primary malignancy is still present. Remember, we don't forget that they have other tumors in their body. It just doesn't go first when we're treating the secondary site. Okay, let's talk about some general complications that we're going to see. So here's the big thing. We just talked about the three main types of therapy. Okay, we're using radiation beams, we're using chemicals to dump into the bloodstream, and we're using immunotherapy to reboot the system. Well, both radiation and chemotherapy cause a lot of side effects. Some of the most common side effects we're going to hear about are things like nausea and vomiting, anemia, as we're going to see codes for, and dehydration is another big one. So because of this, we have specific guidelines to deal with complications of therapy. So as we look at number one, anemia associated with the malignancy. So when the encounter is for management of anemia associated with the malignancy and the treatment is only for the anemia, The appropriate code for the malignancy is sequenced as the principal or first listed diagnosis, followed by the appropriate code for the anemia, such as D63.0 anemia and neoplastic disease. So they're telling us, okay, if it's anemia because of the cancer goes first, then the anemia code. So again, this is where that due to comes in. Okay, the anemia is due to what? If it's due to the malignancy, due to the cancer, we're going to sequence it as cancer first, then the anemia code. But number 2 tells us, when the encounter is for management of anemia associated with an adverse effect of the administration of chemotherapy or immunotherapy, and the only treatment is for anemia, the anemia code is sequenced first, followed by the appropriate code for the neoplasm and the adverse effects, such as T45.1x5, adverse effect of anti-neoplastic and immunosuppressive drugs. So again, in this case, the anemia is being caused by the therapy. Okay, so because it's being caused by the therapy this time, the anemia goes first, then the cancer, and then what we call the adverse effects. What happened? The nausea, the vomiting, the dehydration, whatever came next. Okay, so that's what we want to keep in mind. So this is for chemotherapy and immunotherapy, okay, versus the second paragraph here. When the encounter is for management of anemia associated with an adverse effect of radiotherapy, which is radiation therapy, the anemia code should be sequenced first, followed by the appropriate neoplasm code and code Y84.2, radiological procedure and radiotherapy as the cause of an abnormal reaction of a patient or in a later complication without mention of misadventure at the time of the procedure. So it's the same guidelines. However, they've given us a more specific code to use. So we're still going to do anemia, because that's the main reason why the patient's there, then the neoplasm, then the Y84.2 code, okay, and any other effects that might have happened, all right? So again, we always want to go through how do we code these sections. Now, for number 3, when the encounter is for management of dehydration due to the malignancy, and only dehydration is being treated by intravenous rehydration, the dehydration is sequenced first, followed by the codes for the malignancy. Because again, what are we doing? What are we treating? We're treating the dehydration. The dehydration code goes first, and then the malignancy. Okay, so again, this is why I always tell you guys we need to remember that there is a guideline. Okay, we don't need to memorize these guidelines, but when you start seeing these complications of malignancies, this should give you a good indication, hey, let me go back and check my guidelines to see if there's something more specific I have to do. Okay, now, again, we try to do surgical procedures if we can to deal with these issues. So it tells us, when the encounters for treatment of a complication resulting from a surgical procedure, designate the complication as the principal or first listed diagnosis if the treatment is directed at resolving the complication. So again, if the patient gets a complication, let's say they go into kidney failure, acute kidney failure, okay? And so we are giving the patient a variety of medications to get their kidney function back up, okay? So in this case, the acute kidney failure would go first. Then we can put the cancer and then anything else that's going on, because in this case, we are actually treating the problem, the complication itself. Complication is going to go first. It is the reason for the treatment. Now, what has happened when we go in and completely excise, completely remove a tumor? When a primary malignancy has been previously excised or eradicated from its site, and there is no further treatment directed to that site, and there is no evidence of any existing primary malignancies, a code from category Z85 Personal history of malignant neoplasm should be used to indicate the former site of the malignancy. So again, once it has been completely excised and eradicated from the body, we can then use a personal history of a malignant neoplasm code. Okay, but it goes on. Any mention of extension, invasion, metastasis to another site is coded as a secondary malignant neoplasm to that site. The secondary site may be the principal or first listed with a Z85 code used as a secondary code. So again, the primary cancer could be over and done with, but we could still be treating the secondary cancer, okay, the metastasis. So again, we need to know what else is going on in the patient's body when we're coding, and this should all be documented in the record. Okay. Now again, if we are physically going in and surgically removing the neoplasm, it tells us, when an episode of care involves the surgical removal of a neoplasm, primary or secondary site, followed by adjunct chemotherapy or radiation treatment during the same episode of care, the code for the neoplasm should be assigned as the principal or first listed diagnosis. And the reason is because the patient was going to have the surgery on the neoplasm. If after we remove the neoplasm, we are then going to have the patient do radiation or chemotherapy, that will be coded in addition. Because remember, the main reason for the surgery is the cancer, okay? Now, for number 2, if a patient's encounter is solely for the administration of chemotherapy, immunotherapy, or external beam radiation therapy, assign code Z51.0, which is encounter for anti-neoplastic radiation therapy, Z51.11, encounter for anti-neoplastic chemotherapy, or Z51.12, encounter for anti-neoplastic immunotherapy as the first listed or principal diagnosis. So again, it's just reminding us, if they're there for treatment of one of these therapies, therapy goes first. Now, if a patient receives more than one of these therapies during the same admission, more than one of these codes may be assigned in any sequence. So again, if they get radiation and chemotherapy, either one can go first. Okay. Now it goes on to tell us, okay, the malignancy for which the therapy is administered should be assigned as a secondary diagnosis. So that's finishing up what we just read. So again, therapy is going to go first, malignancy is going to go second. Now, if a patient's admission is for the insertion or implantation of a radioactive element, like brachytherapy, and the appropriate code for the malignancy is sequenced as the principal or first listed diagnosis, code Z51.0 should not be assigned. And this is because brachytherapy is its own special little beast. Brachytherapy are those little seeds that we insert into or put around a tumor. And so these are new guidelines for this year. It's telling us that, again, we're going to use the cancer code as the reason for the encounter and not the Z51.0. Now, as we talked about, we will get a lot of complications, both from the cancer itself and from the therapy for the cancer. So now we're going to talk about what happens when we have those complications. So when a patient is admitted for the purpose of external beam radiotherapy, immunotherapy, or chemotherapy, and develops complications such as uncontrolled nausea and vomiting or dehydration, the principal or first listed diagnosis is Z51.0. Encounter for anti-neoplastic radiation therapy, or Z5111, encounter for anti-neoplastic chemotherapy, or Z5112, encounter for anti-neoplastic immunotherapy, followed by codes for the complications. So again, the first thing that we're going to have to do is we're going to put the therapy, because the therapy is what caused the complications. So we put the therapy code first, then the complications, then we're going to code the neoplasms. Now, it goes on. Again, anything in bold this year, remember, is new. When a patient is admitted for purpose of insertion or implantation of radioactive elements like brachytherapy and develops complications such as uncontrolled nausea and vomiting or dehydration, the principal or first listed diagnosis and the appropriate code for the malignancy, followed by codes for the complications. So, again, this is a little bit backwards. For this one, we are going to code the malignancy first. So what they're doing for this year is they're really trying to separate the differences between the traditional chemotherapy, immunotherapy, and radiation therapy and the higher technology brachytherapy that we can use for only certain cancers. So again, the guidelines are a little bit different. So we see brachytherapy, we want to stop and make sure that we know what guidelines that we need to use. Okay, so again, sometimes instead of going in to get a surgery to remove the tumor, sometimes we're going in to see how large the tumor is. So, when the reason for the encounter is to determine the extent of the malignancy, or for procedures such as a paracentesis or thoracentesis, the primary malignancy or appropriate metastatic site is designated as the principal or first listed diagnosis, even though chemotherapy or radiotherapy is administered. So again, the main reason is the cancer. Why? Because we're going to find out how large the cancer is. All right. So again, let's talk about some signs and symptoms. So symptoms, signs, and ill-defined conditions listed in Chapter 18, characteristic of or associated with an existing primary secondary site malignancy, cannot be used to replace the malignancy as the principal or first listed diagnosis, regardless of the number of admissions or encounters for treatment and care of the neoplasm. So what this is reminding us is no matter what complications are going on, if the patient still has cancer, we need to code that they still have cancer. That is what is important in this one. So we don't forget the neoplasm, even if it's not what we're treating today. Okay. So let's go down here. Malignancy in 2 or more non-contiguous sites, so not touching each other. A patient may have more than one malignant tumor in the same organ. These tumors may represent different primaries or metastatic diseases depending on the site. Should the documentation be unclear, the provider should be queried to the state of each tumor so that the correct codes can be assigned. So again, make sure that we're always very clear. If there's 2 tumors in one site, that we understand if one of them is primary or secondary, or if they're both primary, or what the status of those tumors are. Now, we also have this code C80.0, Disseminated Malignant Neoplasm Unspecified. It is for use only in those cases where the patient has advanced metastatic disease and no known primary or secondary sites are specified. It should not be used in place of assigning codes for the primary site and all known secondary sites. So C80.0 is only going to be used in very specific circumstances. C80.0 is mainly going to be used in the emergency room and hospital setting when someone shows up without having a diagnosis of cancer, and when we test them, we find that they have cancer all through their body. Now, this also can be used for, let's say, a patient who was DUA, dead upon arrival, where perhaps the patient might have collapsed and the paramedics brought them in, and by the time we got them to the hospital, they didn't make it. And when we start doing an autopsy, we might be able to see this. But again, it's not a code that you should ever be billing out for unless absolutely necessary. Now, however, code C80.1, malignant primary neoplasm unspecified, equates to cancer unspecified. This should only be used when no determination can be made as the primary site of a malignancy. This code should be rarely used in the inpatient setting. So just like a lot of our other testing that we deal with, sometimes we find a secondary cancer before we find the primary. And so what we do in that circumstance is if the doctor can confirm the metastasis, the secondary cancer, we then use C80.1, unknown primary cancer, until we can verify where the primary cancer is. So this code C80.1 is not going to be used too often, and it's usually going to be used very early on in the patient's treatment. And once we get an official diagnosis, C80.1 will disappear from the patient's chart, and we will put in the specific primary site. Let's talk a little bit more about sequencing. Okay, so again, when we're talking about sequencing, we're always talking about which way do we want these to go. So if the reason for the encounter is for treatment of a primary malignancy, assign the malignancy as the first listed diagnosis. The primary site is to be sequenced first, followed by any metastatic sites. Why? Because we're treating the primary. So if we're treating the primary cancer, then we want to put that first because that is what we're doing. That is what we're treating. And then the metastatic sites, the secondary cancers, will go after that. But when an encounter is for a primary malignancy, try it again. When an encounter is for a primary malignancy with metastasis and treatment is directed towards the metastatic or secondary site only, the metastatic site is designated as the principal or first listed diagnosis, and the primary malignancy is coded as an additional code because, again, this time we're treating the metastasis. So the metastasis goes first because that is what we are treating today. Then we put the primary cancer. Again, the patient doesn't mysteriously just have it dropped off their claim. It just doesn't go first. So we do have this next circumstance. It comes up rarely, but it does happen. So when a pregnant woman has a malignant neoplasm, a code from subcategory 09A.1, malignant neoplasm complicating pregnancy, childbirth, and the puparium, should be sequenced first, followed by the appropriate code from Chapter 2 to indicate the type of neoplasm. Now, you might be wondering, why do we put the pregnancy code first? Well, when you get to the Chapter 15 guidelines, one of the first things that the pregnancy, childbirth, and the puparium guidelines tell you is if a woman is pregnant, pregnancy codes always go first. They get what we call sequencing priority. So in this case, the 09A.1 is going to go first, followed by the type of neoplasm that the woman has, and then anything else that is going on. Now again, when we're coming in for a complication, we always need to know what complication are we coming in for. So when an encounter is for management of a complication associated with a neoplasm such as dehydration, and the treatment is only for the complication is coded first, followed by the appropriate code for the neoplasm. The exception to this guideline is anemia. When the encounter is for management of anemia associated with the malignancy, and the treatment is only for anemia, the appropriate code for the malignancy is sequenced as the principal or first listed diagnosis, followed by D63.0, anemia and neoplastic disease. So again, in general, unless it's anemia, complication gets coded first, then the neoplasm, unless it's anemia, and then anemia gets coded after the malignancy, okay? Now, what if we have a complication from a surgical procedure? So when an encounter is for treatment of a complication resulting from a surgical procedure performed for the treatment of a neoplasm, designate the complication as the principal or first listed diagnosis. So again, complication first and then everything else. See guideline regarding the coding of current malignancy versus personal history to determine if the code for the neoplasm should also be assigned. And again, this is because a lot of times when we're doing a surgical procedure, it's to remove the tumor. So we need to be clear, are we treating the tumor or are we removing the tumor? Okay, so then we get to what we call a pathologic fracture. So a pathologic fracture is a fracture that is caused by another disease or condition. So it's not caused by a fall or by a car accident. It's caused because of something like a bone tumor. So, when an encounter is for a pathological fracture due to a neoplasm, and the focus of treatment is the fracture, a code from subcategory M84.5, pathological fracture and neoplastic disease, should be sequenced first, followed by the code for the neoplasm. However, if the focus of the treatment is the neoplasm with an associated pathological fracture, the neoplasm code should be sequenced first, followed by a code from M84.5 for the pathologic fracture. So again, this goes either way depending on what we're treating. If we're treating the fracture, fracture goes first, then neoplasm. If we're treating the neoplasm, they happen to also have a pathologic fracture, it's going to go neoplasm, then fracture. So again, what are we treating? What are we discussing during that visit? So let's talk about a current malignancy versus a personal history. So when a primary malignancy has been excised for further treatment, such as additional surgery for the malignancy, radiation therapy, chemotherapy, is directed at that site, primary malignancy code should be used until treatment is complete. So again, if the patient still technically has the cancer in their body, we're going to code it until the treatment is complete and the doctor says your cancer has been eradicated. But as it goes on, when a primary malignancy has been previously excised or eradicated from its site and there's no further treatment of the malignancy directed at that site and there's no evidence of an existing primary malignancy, a code from category Z85, personal history of malignant neoplasm, should be used to indicate the former site of the malignancy. So again, we need to know, does the patient still have it in their body or not? And we need this clarified by the doctor if it's not clear. All right. Now, along with all of this, of course, we have our leukemias or multiple myelomas, malignant plasma cell neoplasms that are in remission versus a personal history. So one of the differences between leukemia and other types of cancers is leukemia tends to go into remission, meaning the person can have a relapse. They can get it again. So when it comes to leukemia, usually what we end up seeing is the patient is treated. If the treatment goes well, they go into remission. However, a lot of patients, especially those younger patients, children and young adults who get leukemia, tend to have relapses. So we have to be careful on whether this is a relapse of leukemia or if it's completely gone from their body. So the categories for leukemia and category C90, multiple myeloma and malignant plasma cell neoplasms, have codes indicating whether or not leukemia has achieved remission. There are also codes Z85.6, personal history of leukemia, and Z85.79, personal history of other malignant neoplasms of lymphoid, hematopoietic, and related tissue. If the documentation is unclear as to whether leukemia has achieved remission, the provider should be queried. So again, we need to have clear information from the provider about what is going on with the patient's leukemia. Are they in remission? Did they have a relapse? Or is this truly a personal history now? So you can see we're going to have other guidelines that we're going to see at a later date for this. But we have one last guideline, and this has happened before, and so this is why we have a guideline for it. A malignant neoplasm of a transplanted organ should be coded as a transplant complication. Assign first the appropriate code from category T86, complications of transplanted organs and tissues, followed by a code C80.2, malignant neoplasm associated with transplanted organs, and use an additional code for the specific malignancy. So because this is both a transplant complication and cancer, the transplant complication code goes first, then the fact that it is a malignant neoplasm of a transplanted organ, then the exact type of cancer the patient has. Okay, So, a couple things that we need to keep in mind about coding for neoplasms. Number one, we need to know their behavior. Okay, are they benign, in situ, malignant, or of uncertain behavior? Okay, then are they primary or are they secondary if they're malignant? Again, we want to know either the proper histologic name, like malignant plasma cell carcinoma, okay, or we can have, cancer, primary cancer of the breast, and then we can look that up in the neoplasm table. And remember, with all of these, we are always double checking in the tabular to make sure that we are properly picking out the most specific code that we can get. All right, guys, have a great day and keep coding.